Okay, good morning, everybody. Welcome to Wednesday Morning Rounds. Dr. Boodhwani approached me last fall, actually, and said I had a great idea for rounds, and he did. So it's my pleasure today to welcome the Aorta team to present to us on the contemporary management of thoracic aortic disease. This is a group presentation from numerous team members. So Dr. Jodi Heshka, Dr. Ming Guo, Kathryn McLean, the nurse in the Aorta clinic, and Dr. Munir Boodhwani, one of our surgeons, along with Dr. Gao, one of our surgeons. So welcome to the team, and we look forward to your presentation.
Thank you, Ellie, for that introduction. It is a bit timely that we're presenting on aortic disease today. As we were planning for this talk, I was kind of reflecting on where the program has come from and where it is today. And I remember actually standing at this very podium in 2010 when we had actually proposed, we pitched the idea to the Institute about an aortic clinic. So it's almost 15 years ago now that we had done that. And we talked about, how this is the first time consolidated joint initiative between cardiology and cardiac surgery with involvement of many other disciplines to truly address aortic disease in a multidisciplinary manner. And it was actually in 2010, that was the first year that a formal guideline statement from the American societies had come out. And this was the first time that aortic disease had been addressed independent of valvular disease and other modalities and connective tissue disease guidelines. So it's been close to 15 years that we've been at this in Ottawa. And I would dare say that we were one of the first multidisciplinary aortic programs that emerged in Canada. There were a couple before us that I'm aware of, but not too many. What does the thoracic aortic team look like today? It is truly, I would say, a multidisciplinary effort with cardiology, cardiac surgery, vascular surgery, genetics, cardiac anesthesia, a lot of support from our cardiac rehab teams, psychology, radiology, and even rheumatology for the inflammatory arthritis. But what really holds the group together is our aortic clinic coordinator, Kathryn, who we'll hear from later, as well as our admin team that kind of gets through the large volume of patients that we end up treating. The reason why this particular presentation is a bit timely is that there have been two relatively recent guidelines documents that have come out. One from the American bodies, which include the ACC, AHA, but also participated by other societies like the American Society of Radiology, Vascular Surgery, etc. And then the second is the European equivalent of that with participation from the Society of Thoracic Surgeons as well. And so, we'll talk a little bit later about how the evidence base in aortic surgery has not changed a whole lot, but the guidelines certainly have. And there's a lot of nuances and differences in the way that we start thinking about aortic disease. So I'm here basically just to introduce the team members who are kind of the face of the aortic clinic. So Jodi has joined us a couple of years ago now from the OCC. She's taken on a large load of medical management of thoracic aortic disease. So she's going to be talking to us about medical approach to thoracic aortopathy. Ming, who's recently joined us just this year after a fellowship in both complex endovascular aortic disease as well as open surgery, will be talking to us about surgical indications and management. Kathryn will talk to us about how the thoracic aortic clinic functions and outside of clinical support, what it hopes to provide our patients. And I'll say a few words about research thereafter. So maybe I'll just invite Jodi to take over from here.
Thanks, Munir, and thanks for having us here today. So this is a huge topic, needless to say. I'll try to touch base on what I think are probably the most key messages from the latest guidelines and where things are at currently. So as Munir was saying, there are a few different guidelines that have come out recently in addition to our own CCS guidelines. I'll remind you that there are a variety of thoracic aortic diseases, including, of course, the acute aortic syndromes, which I think Ming will talk to you guys a little bit about, but also intramural hematoma, penetrating aortic ulcers. We do see these. They're not very common, but certainly these are patients that we follow in our clinic, and they're ones where there really isn't a lot of great data to help guide us. I won't go into these in too much detail because really what I want to focus on today is the bulk of what we see, or at least the bulk of what I see from a medical perspective, and that's thoracic aortic dilatation and aneurysms. So this is making up to about 3% of the general population. It's probably, the prevalence is probably even higher than that because, as you know, many people walk around not knowing that they have aneurysms. But of those that we do see, about a quarter of them have these due to heritable or genetic causes. So this is a good number of patients that we're seeing regularly in clinic. And again, this is likely an underestimation because, again, there are many patients who don't have obvious syndromic presentations of aneurysms, and so unfortunately go undiagnosed. Most aneurysms and aortic dissection or dilatation affect the aortic root or ascending aorta, followed by the descending aorta, and less commonly the arch and the thoracoabdominal aorta. And we do tend to still see these more commonly in men, but it's important to appreciate that women tend to have poorer outcomes. This was noted on some research that was done here by some of our colleagues at OHI, Dr. Crozier, Dr. Coutinho. They showed that women actually experience faster growth, higher risk of dissection at smaller diameters. They have increased mortality with dissection, and they have more post-op complications. So we are seeing rates of thoracic aneurysm and aortic dissection gradually sort of trend upwards. This is probably because we're picking them up a lot more than we used to, but fortunately, mortality rates over the last 20 years or so have come down. Okay, so I think one of the really important take-home messages today is that it's important to have a good appreciation or a good understanding for what ultimately we think is driving the aneurysm or ultimately the dissection. The majority of thoracic aortopathy remains degenerative in nature, so about 70% or so of aneurysms are related to age, atherosclerosis, hypertension, smoking. But we are seeing a good number of these being having a genetic background. We do see some inflammatory conditions, and of course, we collaborate quite closely with rheumatology for patients who have giant cell arteritis with aortitis, Takayasu's arteritis, Behçet's disease, ankylosing spondylitis. We have a number of IgG4 and ANCA-related aortitises that we're following quite closely. Patients with congenital aortic disease and other things like Turner syndrome, coarctation have an increased prevalence of aneurysms. I'll remind you, bicuspid aortic valve is about 2% of the population, and up to about 75% of these patients will go on to develop aneurysms or aortic dilatation. So this is a significant disease in that population. Infectious and traumatic causes we don't see that often. So something that I think the more recent guidelines have really tried to focus on more so is differentiating the heritable from the non-heritable, and within the heritable causes of thoracic aneurysm and dissection. We can break this down to patients who are syndromic versus those who are non-syndromic. So syndromic refers to patients who have clear clinical features of a connective tissue disorder. So these are your Marfan patients, your Loeys-Dietz, vascular Ehlers-Danlos. This class of patients is growing as they find new genes on a regular basis, as they see different collections of features. This list is just expanding, but the top three in that box are the ones that we see on a fairly regular basis, with Marfan syndrome obviously being the most common. The non-syndromic heritable forms of thoracic aortopathy are the ones that are probably the most challenging, because these are patients who really have no obvious clinical features. They may or may not even have family history to speak of. So it's a little bit more challenging to find these patients, particularly when they might have other confounding risk factors like smoking or high blood pressure. So out of these forms of aneurysms, the ACTA2 gene mutations are probably the most common cause, but there are a number of other mutations, and these make up to about 30% of heritable aortopathy. So when we refer somebody to genetics, about 30% of the time, they're able to locate an actual genetic variant that's associated with the aneurysm. And in that group as well, we categorize all of these patients who have, you know, the aunt, the uncle, the parent who had aneurysms, who had a dissection where there's no identifiable genetic variant that can be located at this time. And then to complicate things a little bit more, there are actual genetic conditions or gene variants that cause both a bicuspid aortic valve and an associated aneurysm. So you can see how everything can get pretty murky. And so there's a lot of thought that needs to go into what is actually going on here. So this was a study that was done not too long ago, and they've looked at a cohort of patients who had clear heritable aortopathy. And you can see, you know, there's a huge variety of genes, and this list every year gets much larger. And so typically we refer patients back to genetics about every 5 years if there's no gene identified, so that they can be retested, because by that point there are a lot of other genes that can be tested for. So obviously, when you're trying to classify an aneurysm, the typical atherosclerotic risk factors are important: age, smoking, hypertension, etc. Family history is really important, and it's important to go back at least 2 generations, if not more. And it's important to ask people about their kids as well. I mean, more and more we're seeing, you know, young adults with school-age children who, where the adult is being investigated for an aneurysm, and I hear many times, you know, from the parent, oh, you know, my son is being referred to CHIO because, you know, he's abnormally, you know, 1.5 feet taller than the rest of us and is super, super flexible. Well, that's a little bit abnormal, particularly or that's a little bit concerning to me, particularly in somebody who is otherwise fairly young and has a dilated aorta. The other things that are important to ask about myocardial infarctions. So we still have a large generation of patients whose parents or grandparents died suddenly. It was called an MI. There was no autopsy. Details weren't known. That actually could have been an aneurysm or dissection. So we spend a lot of time kind of going through the various family history, and I ask patients frequently to come back with additional information or to go looking for it. So briefly, just to kind of review some of the common or more common heritable thoracic aortic aneurysms. Of course, Marfan syndrome is the one that we see most commonly. This one is usually fairly straightforward to diagnose. Patients are quite syndromic normally, although there can be people who are a little bit less syndromic. We have the revised Ghent criteria to help make the diagnosis. Really, you know, if you see somebody who's got ectopia lentis, that's almost pathognomonic, but it's a combination of the degree of aortic root dilatation using a Z-score greater than or equal to 2, and some combination of the clinical features which are on the right side of that slide there. The other 2 conditions that we see not that uncommonly, so Loeys-Dietz syndrome. We follow a number of patients with Loeys-Dietz in the clinic. These patients tend to have aneurysms in other places. So they have a branch vessel aneurysms in addition to the thoracic aortic aneurysm. They often will have mitral valve prolapse. You know, so if you're seeing an aneurysm and mitral valve prolapse on an echo, you know, in the back of your mind, you should probably think, could this be something? They often have a lot of arterial tortuosity. So you'll, and typically these things are almost picked up incidentally. You know, there's an aneurysm. And by the way, you know, you look back in the imaging and an ultrasound of an abdomen 5 years ago showed, you know, these tortuous iliacs. So that's, you know, sort of should raise a little bit of a flag. vascular Ehlers-Danlos syndrome. So this is a very high risk form of genetic aortopathy. These patients are prone to arterial rupture, aortic dissection at small diameters, organ rupture. And so these patients are followed quite closely in our clinic. They are notoriously hypermobile, so really flexible, and they get a lot of easy bruising. So those can be some of the things to look for. The features associated with syndromic heritable thoracic aneurysm are actually fairly common and not necessarily that hard to inquire about if you take the time to sort of inquire about it. So there's a wide variety of features, craniofacial, ocular, cardiovascular, MSK related, skin features. I think we all sort of tend to think about the really, really tall, long limbed, long fingered patient. But patients who are hyperteluric, so very wide set eyes, that can be a sign. The bifid uvula is sort of a classic. Ectopia lentis, very classic. The pectus, very classic. But having a lot of stretch marks, more than you would expect for someone who's not been pregnant or someone who hasn't had significant weight fluctuations, recurrent hernias. There was a study done some time ago that showed a correlation between inguinal hernias and thoracic aortic disease, very wide or atrophic scars. Lots of things that can kind of help suggest that there might be something heritable going on here. So referring to genetics, so this is touched on in the different the guidelines coming out of Europe and here in Canada and the States. And everybody seems to fairly agree with the indications for referral. So having thoracic aortopathy at a young age, so under 50 years of age, is abnormal. And that would prompt a referral to genetics. Having an aneurysm under 60 in a first degree relative raises the flag of something genetic, or having an aneurysm under 60 and absolutely no cardiovascular risk factors, so no high blood pressure, no smoking history. That's a little bit unusual. Obviously having arterial tortuosity or flocculi. So flocculi, I'll bet I don't actually really look for. You need to have a good ophthalmoscope, these tiny little pigments around the iris, but certainly arterial tortuosity is an indication for referral in the context of an aneurysm. Someone who's obviously syndromic, that's sort of a no-brainer. Or in general, because there is still so much we don't know about this condition, some of the guidelines actually say, you know what, if something just doesn't seem right, if there's a high clinical suspicion that something going on, that there's something going on, you should refer them for genetic assessment. So imaging, echocardiogram is the most common tool we use. And in fact, I think probably a lot of our aneurysms are picked up incidentally or are by patients being told to go get an echocardiogram because someone in the family has an aneurysm. It's obviously readily available, but the problem is that it really only kind of gives you the ascending aorta, the proximal thoracic aorta, so it's not ideal for the entire thoracic aorta. So generally, all the guidelines say, when you pick up an aneurysm at the baseline, there should be at least a one-time CT or MRI to take a look at the entire thoracic aorta and get an accurate assessment, accurate measurements, and a good look at the aorta. Clear downsides, CT, MRI cost, availability, radiation with CT. But these still kind of remain cornerstone therapy or cornerstone tests for us to use for imaging. I'll talk a little bit more about sort of the frequency with which we should be following patients or surveilling them with imaging. So for the last little bit, I really kind of want to hone in on surveillance and medical management, because I find that this is where I think people are a little bit lost, and there really is there's still a lot of that's lacking. There isn't necessarily a lot of clarity in terms of how to manage these patients or how frequently to follow them. So beta blockers are something that we've used historically. This was based actually on a very small study that was done in Marfan syndrome patients, where they showed that in these patients, so young adults and adolescents, treating them with a beta blocker, specifically atenolol, slowed aortic dilatation and increased survival. And so from there on, that sort of became the gold standard treatment for thoracic aortopathy. But again, this was not all patients with thoracic aortic aneurysms. This was Marfan syndrome patients. But nonetheless, that was what was sort of adopted. There have been a number of studies and meta-analyses that have looked at non-Marfan syndrome patients since then, and the data is not really as consistent. So again, looking in children and young adults, one study showed that post-op, so post-repair beta blockers increased freedom from needing repeat operation. A meta-analysis in 2020 looking at abdominal aortic aneurysms showed that beta blockers really had no effect on growth. And then another review of 9 clinical trials in a combination of Marfan and non-Marfan patients really concluded that there was they couldn't actually come to a conclusion. There was insufficient evidence to support the routine use of beta blockers in non-Marfan patients. Now, something that is new that has come out in the last 2 years or so is that in Europe, there has been some really positive data with celiprolol, which is a beta blocker, and this is specifically in vascular Ehlers-Danlos syndrome patients, where patients did better when they were treated with this particular beta blocker, but this is not available in Canada. So for Marfan syndrome patients, there's an indication to treat them with a beta blocker or an ARB, which I'll get to. But really in other non-Marfan patients, the data is less clear. The American guidelines sort of extrapolate and suggest for genetic aortopathy in general, it's reasonable to use it if there's no downside or no contraindication. So RAS blockers initially were hypothesized to be useful because they are known to affect TGF beta signaling, and TGF beta is a gene variant that is associated with aneurysms. Again, a lot of the data comes from studies in Marfan syndrome patients. The use of ARBs and the reason why they're supported, the use is supported in guidelines comes initially from the COMPARE trial. So this was a study that treated Marfan patients with aneurysms under 5 centimeters with losartan, and they showed that the aortic root dilated slower. And interestingly, the control was included a beta blocker. They also went on to do an 8-year follow-up study that again showed that there was reduced risk of death, dissection, need for vascular grafts beyond the root, and a composite endpoint using losartan versus a control or a beta blocker. Other studies have looked at ACE inhibitors, ARB versus beta blocker in Marfan syndrome, and conversely to the COMPARE study actually really didn't find a big difference. And other studies yet have looked at the population of patients with bicuspid aortic valve and showed that really ARB or beta blocker both are beneficial post-dissection repair. Finally, there have been some studies looking at ACE, ARB plus beta blocker, so the combo therapy, and really there's been no good evidence to support that combo therapy is any better than monotherapy with one or the other. So finally, you'll see, if you see any of my notes coming out of a clinic, or if you see sort of the notes from genetics, there's a little blurb that we include saying, try to avoid CCBs, particularly with genetic aortopathy. And this is because, again, in Marfan syndrome patients, there have been a couple of studies that showed worsening aneurysm progression in children and young adults. We don't really know. It hasn't been studied in other genetic aortopathies. So again, the recommendation has been sort of extrapolated. But generally, we discourage using them in genetic aortopathies unless they're really needed for refractory hypertension or patients are not tolerating beta blockers or ARBs. There conversely has been some benefit that they might be beneficial post-EVAR, but again, the data is very controversial. So to sort of sum up, the use of these medications. So in Marfan syndrome, there's a clear indication for either an ARB or a beta blocker, and this is endorsed by our guidelines, the Americans, the Europeans. Max tolerated dose is what's recommended. The beta blocker that's been studied the most is atenolol. The ARB is losartan, but that being said, generally the class is used. Blood pressure management is very important, and that's because we know that there's increased mortality if blood pressure is over 140/90. The guidelines suggest a target of less than 130/80, and being more aggressive, so it's systolic of less than 120 if there is any degree of dissection. There are no specific guidelines in terms of medical management for other genetic aortopathies. The Americans come out and say, for other genetic aortopathies, it's reasonable to use ARB or beta blocker. And so often we will empirically treat these patients, but again, the data is not necessarily there. And interestingly, Dr. Dietz of Lois Dietz has done some animal studies with vascular EDS patients and has shown that there's a reduced risk of spontaneous aortic rupture and death with spironolactone. And so he and his clinic of vascular EDS patients empirically treats all his patients with 100 of spironolactone. I have been treating some of my patients with this. I will admit that a lot of these are young women who have low blood pressure to begin with, and so getting them on 100 of spironolactone is challenging. I think I'm going to run out of time soon, so I'll move along quickly. Statins, very important part of vascular protection. We have been a little reluctant to use them consistently in younger patients with genetic aortopathy, but I will remind you that statins have a pleiotropic effect, and so beyond just general vascular protection, they can reduce inflammation, oxidative stress, endothelial dysfunction, and all of these are mechanisms that have been shown to be pathologic in terms of aneurysm formation. A lot of the data comes from abdominal aortic aneurysms. We don't have great data in thoracic aortic aneurysms, but really there's not much downside to treating a patient with a statin. So increasingly we're using these in all thoracic aortic aneurysm patients. I'll skip over this. I can certainly answer questions about that if anyone wants. And again, exercise recommendations. We're really trying to avoid sudden rises in blood pressure because it's associated with increased risk of dissection. Okay, so I want to just spend a few minutes talking about this. So this is from the ESC guidelines, and I think for people treating aortopathy or following these patients, it's a nice summary. So this is sort of the first time that really there's been this sort of focus on adjusting your surveillance based on size. And we know that larger aneurysms are associated with increased risk of dissection. And also it emphasizes sort of the role of CT or MRI in looking at the entire thoracic aorta and also verifying dimensions. So as you can see, smaller aneurysms, so 4.4 centimeters or smaller, baseline CT, again, to take a look at the entire aorta, following up in 1 year to measure growth rate. And if things really are not moving very quickly, so less than 3 millimeters enlargement or progression, then that's somebody that can be followed every 2 to 3 years, and echocardiogram is probably pretty reasonable. Larger aneurysm, so between 4.5 and 4.9 centimeters. Again, you want to confirm with CT or MRI at baseline, and it's recommended that you perhaps consider re-imaging in 6 or 12 months to see growth. And again, if stable, these are patients you're going to follow a little bit more frequently, so typically annually, or more often if you're seeing more than 3 millimeters change per year. And then around 5 centimeters is where we're starting to kind of approach the surgical threshold, and Ming will be talking to you about that. But this is where the European guidelines really support looking at sort of the phenotype. So is this a root aneurysm? This would be something that would be a little bit more concerning. And so they support, at that point, kind of considering surgery if they're 5 centimeters or bigger. If it's an ascending aorta aneurysm and there aren't any high risk features, then your options really are to monitor. You could still consider surgery if risk is low. Bigger than 5.3 centimeters, really the Europeans are fairly supportive of sort of starting to talk about surgery with these patients. This is really challenging because we don't really know what a normal aorta size is for any one given person. So it's something that is really kind of debated a lot, but it's a nice sort of a systematic way of at least trying to approach these patients in a consistent fashion. And then the other thing I just want to kind of mention is that with genetic aortopathies, again, these patients are prone to tortuosity, aneurysms, dissections in other places. So the Americans in particular do a really good job of coming out with, how often should we be screening Loeys-Dietz, Ehlers-Danlos, et cetera. So Loeys-Dietz patients should have head to pelvis imaging every 1 to 3 years, depending on location and what's found. They've extrapolated to say the same for vascular EDS patients. And I would say really, head to pelvis imaging should be considered for any patient with arterial tortuosity, fibromuscular dysplasia, symptoms or family history of aneurysms or dissections in other vascular beds. So I will pause there. I'll hand it over to my colleague Ming to take it from here. Thank you.
Thanks, Jodi. That was really comprehensive. We'll talk a little bit more about the significant changes in the surgical indications between the guidelines. So first, to start off, for aortic root and ascending aortic aneurysm, that's sporadic in patients with tricuspid aortic valves, Class 1 recommendation firmly sits at 5.5 centimeters for intervention. This is the same as before. However, in the new guidelines, the Americans and European guidelines both made a new Class 2A recommendation for surgical intervention at 5.0 centimeters or 5.2 centimeters with a qualifier by experienced surgeons or with low surgical risk. And the experienced surgeon and low surgical risk qualifier also applies now to concomitant cardiac surgery and AVRs and alters the indication size indication based on that. And in addition to that, there's new Class 2B recommendations being made, incorporating index aortic sizes, such as cross-sectional area to height ratio, aortic size index, and aortic height index, accounting for patients with smaller statures and potentially with smaller baseline aortic size. For patients with bicuspid aortic valves, again, the Class 1 indication sits squarely at 5.5 centimeters for intervention, with the Europeans adding a root phenotype as a modifier to lower the threshold to 5.0 centimeters, which is new. Class 2A recommendation, again, is new, operating at 5.0 to 5.2 centimeters for patients with high-risk features and by experienced surgeons or with low surgical risk. And lastly, the Americans recommended a 2B recommendation for 5.0 centimeters for patients with no high-risk features and by experienced surgeons. So let's take a look at some of the evidence behind the changes in the guidelines. So the initial initial 5.5 centimeters comes from the Yale study, where they identify inflection point of 6.0 centimeters at which the risk of dissection and ruptures increased significantly. They've since looked at more of their patients and more refined data, and in fact identified 2 hinge points in their patient population, one at 5.25 centimeters, where the risk increased from about 0.5 to 1 to 4%, and one at 5.75%, where 5.75 centimeters, where the risk increased to about 8%. There's also been studies that looked at patients, compared patients with dissections, comparing their CT scan just before they had dissection and on their dissection, and they found that the aneurysm size actually increased by quite a bit to about, on average, about a centimeter between but between the CT scans for patients who had before they had a dissection versus on the day of their dissection. So in fact, the CT that we see, the aneurysm size that we measure on dissection is in fact bigger than what they their aneurysm is before they had an event. In 2007, we know from the International Register of Aortic Dissection database that in fact 60% of patients who experience dissection has aortic size less than 5.5 centimeter, which is our guideline surgical threshold. So based on all the studies, there is a question and a push in the field to say that, you know, is this a time, because our surgical outcomes are good, to move the aortic guideline leftwards, lowering the threshold from 5.5 centimeter to 5.0 centimeters, thereby capturing more patients with aortic aneurysms that may potentially have dissections. So, you know, what is the evidence enough to support this? In 2018, our group did a meta-analysis looking at patients with, or looking at studies who had done for natural history of thoracic aortic aneurysms. And we found that the annualized combined rate of aortic dissection and mortality is around 2% for among all the studies. As you can see here, highlighted by the red circle, that's the Yale study. And it's a bit of an outlier compared to all the other studies that's out there looking at natural history of these patients. There's a study in the North Carolina population of over 6,000 patients where they looked at patients with thoracic aortic aneurysm. And the bottom line is that they found an inflection point dissection risk at 6.0 centimeters, but not lower. And more recently, just a couple months ago, there's a study in the Danish population of over 10,000 patients that were prospectively followed. The bottom line of this study is that the average risk of adverse aortic events amongst all groups between from 4.0 centimeters to more than 5.0 centimeters are low, and that in fact family history in this study predicts the risk of dissection better than aortic size. So if aortic size is not the best way to look at the risk for dissections or rupture, is index size better accounting for a patient's body habitus? Unfortunately, this is all the study we have on index sizes and their prediction, their potential prediction for aortic events. And essentially, one paper for each index size. So the index size should certainly be used as a supporting tool, but certainly not a definitive measurement that we can use to support our surgical decisions, and more studies definitely needed. So to summarize, for patients with sporadic aortic root and ascending aortic aneurysms, some major changes include intervention at 5.0 to 5.2 centimeters for experienced surgeon or low surgical risk. The addition of index sizes and other aortic parameters to guide surgical intervention threshold is included. And lastly, similar intervention threshold are proposed for tricuspid and bicuspid aortic valves. Moving on to patients with aortic arch aneurysms, class 2A recommendation for intervention at 5.5 centimeters. For patients with descending thoracic aortic aneurysm, it's also at 5.5 centimeters as before as well, with a class 2B for less than 5.5 if there's risk factors. For patients with thoracoabdominal aortic aneurysms, there's a class 1 recommendation for 6.0 centimeter for intervention, because intervention for these patients are usually more risky and complex. But they have also lowered the recommendation to 5.5 centimeters, qualified by experienced surgeons or high risk factors. For Marfan syndrome, for aortic patients with aortic root and ascending aortic aneurysms with Marfan syndrome, there's no question that class 1 indication for surgery is 5.0 centimeters. They've also made a class 2A recommendation for 4.5 centimeters to operate for those with high risk features and for those for surgery by potentially experienced surgeons. On the other hand, lower states, in fact, received quite a bit of changes in terms of a bit of a nuanced approach towards approach based on the genetic variant identified. And so the surgical threshold now can range from 4.0 to 5.0 centimeters, depending on exactly which gene the patient has and depending on some of the high-risk features that they have. And lastly, for patients with non-syndromic hereditary thoracic aortic disease, there's a class 1 indication for operating at 5.0 centimeters, and for less for patients, again, with high-risk features or operated by experienced surgeons. Moving on to talk a bit more about dissections. So traditionally, we've identified dissections based on the Stanford classification or the Baker classification, with Stanford classification being the most commonly used as it pertains really well to surgical urgency as well as the risk of complications from dissections. But these classifications, aside from the fact that whether ascending aorta is involved, doesn't really tell us any more information about the dissection, such as the location of entry tear, complications from it, and how the patient is doing. In 2020, the Society of Vascular Surgeons, together with some of the surgical societies, came up with a new classification system. In this classification system, you identify type A or type B dissection based purely on the location of the entry tear. So if the entry tear is in zone 0, the patient has a type A. If the entry tear is zone 1 or above, the patient has a type B. In addition to that, they added a way where you can identify what the proximal extent of the dissection is and the distal extent of the dissection. And more recently, the European guidelines proposed a TEM classification based on type, entry tear location, and malperfusion. So in this guideline, in this classification, you will identify the type based on Stanford classification first, and then you identify the entry location based on ascending arch or descending, and also qualifiers of malperfusion based on what kind of malperfusion syndrome the patient has. Now, this classification gives us a lot more information about the dissection, but it's actually pretty complex to use, and you have to remember a lot of things. But one of the most important, interesting point coming out of this classification is that they've identified a classification of non-A, non-B aortic dissection, where the management could potentially be a bit different. And non-A, non-B is essentially when the ascending aorta is not involved, but the aortic arch is involved. So what does that mean? So essentially, type A dissections, as usual, you proceed to emergency surgery. Type B dissection, as previously recommended as well, where you would proceed with intervention for complicated cases or patients with complicated features or medical therapy based on that. They've added a new algorithm for non-A, non-B dissections, which is a bit more complex. And the bottom line is that these patients really required a more nuanced approach and assessment on an individual basis on whether the timing of surgery as well as the type of surgery. And we can certainly talk a bit more about that when there's a bit more time. I'll answer a bit more questions if there is. And so we've talked about the surgical indications. Let's talk about a bit about things that we do in the operating room. For patients with aortic root pathology, we can do a Bentall procedure where the aortic root aneurysm and the aortic valve are both replaced. Or for patients with a sparable valve that looks good, we can do a valve spraying procedure where the aortic valve is preserved and the aneurysm is excised around it. For patients with ascending aortic pathology, we can do ascending aortic replacement, or if the aneurysm encroaches upon the aortic proximal arch, we can do a hemiarch under hypothermia and circulatory arrest. For patients with aortic arch pathology, this is where it gets a bit more interesting. We have the traditional complete open approach where the aortic arch and the 3 head vessels are entirely replaced. We have the hybrid approach where the different levels of the arch as well as different numbers of the cerebral vessels are replaced or debranched, and a endovascular TEVAR graft is placed. The benefit of this approach is that sometimes we can avoid hypothermia and circulatory arrest or even cardiopulmonary bypass, and that the presence of a TEVAR graft allows for future extension down the line to treat the distal pathology. And lastly, more recently, we have a total endovascular solution for patients with aortic arch pathology. There's endovascular aortic arch intervention has been around for over a decade. There's many different ways to do it, but more recently, a branch device is the one that's been more used in the field and more recognized and studied. There are 4 different types of commercially available customized branch devices. We've used 2 of them here because these are the ones that's more available for us. The Cook device as well as the Gore device. We've done about 5 of the Cook device cases and about 2 of the Gore device cases. Now the patients have done well, but these devices remains only available or should be only available for patients with high or prohibitive surgical risk patients, as more study will be required to determine the short-term and long-term outcome of these devices. For descending thoracic aortic pathology, traditionally you can apply a TEVAR graft down it. But if the aneurysm or the disease encroaches upon the distal part of the arch, you have to do a carotid subclavian bypass in order to place the TEVAR, or you do open surgery. And again, more recently, there is a way to do this from an complete endovascular perspective, where we do in situ fenestrations for the TEVAR that lands at zone 2. This avoids the need for a cardiac subclavian bypass, and we've done 2 of these cases here, led by Dr. Al-Tassi. But there's also now a few single branch devices. This one is the Gore TBE device, where you don't even need to do a fenestration. The branch is incorporated within the graft, and it's a single stage solution for patients that needs a zone 2 TEVAR with a single branch device. And we've done about 2 cases of that here as well. And lastly, for patients with thoracoabdominal aortic pathology, there's the traditional approach of open surgery, and there's also the complete endovascular approach with branch and fenestrated devices. And so, as you can see, there's a lot more different ways to do aortic arch and thoracoabdominal aortic surgery nowadays, combining open and endovascular approach. And this is where a multidisciplinary aortic team, including us, vascular surgery and interventional radiology, is really, really beneficial, where we discuss these cases together and really determine what's the best approach and best treatment option that will give the patient the best outcome. I'll hand over to Kathryn.
Good morning. Thank you. So I would like to share some information about our aortic clinic here at the Heart Institute. So just some brief statistics here. As Dr. Boodhwani mentioned, we have been functioning since about 2010, 2011, so almost 15 years. Our referral numbers have increased over the years, and now we're up to about 250 to 300 patients every year. Our database includes over 3,900 patients, and those include both active and inactive patients. We have about 15 to 20 clinics per month. And I looked at the statistics from last year, and the number of consults we saw last year was about 330, and follow-up appointments were 570. So almost about 900. And I'm just going to say that since Dr. Heshka has joined us, I'm sure these numbers have increased significantly, because she sees a lot of patients every week for us. Our team includes 7 physicians made up of surgeons and cardiologists, myself as the nurse coordinator, and then we have our allied medical professionals that work along with us as well, and our administrative assistants. These are our medical providers. So you all know most of everyone. There's Dr. Boodhwani as our director. Then we have Dr. Guo, Dr. Al-Tassi, and Dr. Masters. On the cardiology side, we have Dr. Chan, Dr. Beauchesne, and Dr. Heshka. So just wanted to touch on the referral process, just so that if you do want to send anybody our way, it's clear, because sometimes there's some questions about that. Referrals internally can be made through the Epic system, and you can enter an order either through cardiology referral or cardiac surgery referral. Externally, we take referrals, which are just faxed to us, and that's our fax number if anybody needs that. So just wanted to show you in Epic how it looks. And now this is the cardiac surgery referral page. And what's important here, because I know some people get stumped on this one, you need to check here where the it says is a patient admitted or not. So it's yes or no. So when you click on no, then what you do see is this page, which will give you more information. So it tells us, what kind of patients you're referring, and you would want to select aorta, which is the first hard stop there. And then the rest of the questions are quite self-explanatory. When you click on aorta, then that brings you up to what type of pathology the patient has and what kind of imaging they've had. And then this comes to our referral work queue, and then I triage the patient, and so that works well. The other way, of course, is to refer through cardiology, which also works. And again, this page looks a little bit different. And at the hard stop there for the subspecialty, directly on the right-hand side, you'll see referral UOHI aorta, and that's what you would click on. And then again, at the lower part of that page, you would select where the pathology was and what kind of imaging was done. So it's simple, but there's just a couple steps that if you don't make them, it doesn't proceed, and people then get wondering if it's going to make it through to us. Lastly, I'd just like to mention a few of the clinical initiatives that we have in the aortic clinic. For probably about the last 7 years, I've been doing the aortic disease support group. And this came out of a need for our patients who don't fit the mold of our typical rehab type of support groups. In that, I mean, they don't have coronary artery disease typically, they don't have heart failure, they don't have valvular disease. So we meet every second month, and I usually have a guest speaker, and we talk about different topics related to general cardiac care or aortic care and lifestyle and quality of life and that kind of thing. So we meet, and it's been a very good success. We now offer it in a hybrid fashion, so we get patients from different parts of the province, different patients that are members of the, the support groups for Marfan or Lloyd's Dietz. They also join us as well. So it's been a success, and patients enjoy that. We're now having patient participation in more of our research trials. So we're on the lookout for patient partners who are interested to assist us in these processes. I also have patient partners that we use to assist the preoperative patients as a support to the patients and helping them understand what this surgical experience is going to be like. We do have an aortic disease information booklet, which provides our patients with information, and the format's very similar to a lot of the other Heart Institute booklets, but it's tailored obviously to aortic disease, and so we've had good success with that and good feedback from the patients. And lastly, in the last 6 months, I've taken up having nurse-led follow-up clinics for Dr. Boodhwani's patients. So once Dr. Boodhwani has established that their aortic pathology is stable, and we're repeating their imaging yearly or 6 months or whatever the time is, I do have a clinic set up where I will call the patients and go through, any symptoms they may be having, what their blood pressure is, what their activities are, anything that's related to their disease process. And then based on the medical directives that Dr. Boodhwani has given me, then I can, indicate whether we're going to repeat the imaging and what type of imaging it is and that sort of thing. So that's been very successful for us because we can ensure that patients do have consistent follow-up on a yearly basis. And that's it.
Fantastic. Thank you. It's 8:22. I know people are itching to get on with their day. I'm just going to spend a couple of minutes about the research efforts that have occurred over the past decade and a half in the thoracic aortic program. There's been a lot of research around using our local data of the close to 4,000 patients that we follow within the thoracic aortic clinic. But I point out that if you look at this slide, looking at the guideline statements that have come out over the years from 2010 on the left to 2023 on the right, in the red sliver are the number of recommendations that are actually guided by RCTs. So less than 1, maybe 1 to 2% of all recommendations made around medical therapy, imaging, surgical indications, and management are actually tested in RCT. So there's a huge gap in the quality of data that we use to treat our patients. And so one of the things that we've embarked on in partnership with a lot of different sites are a few randomized trials in thoracic aortic disease. The first one being the Titan SVS trial. So this is a CIHR funded trial that looks at aneurysms in the gray zone, the 5.0 to 5.5 centimeter range, and they're randomly assigned to surgery versus surveillance. And there's a parallel registry that enrolls a large number of patients now, and I would say one of the largest registries, multi-center prospective registries on thoracic aortic disease of that size. success of that trial basically enabled us to make a network, and we now have a network of close to 30 centers in North America, Canadian and American, and now soon branching out to Europe, which has now embarked on total of four projects, so 3 additional projects related to thoracic aortic disease. And these are at various stages of completion. Some of them are at, the trials are about 30 to 40% enrollment. Others are in their pilot phase. This is the second trial. It's called the COMMENCE trial, looking at different temperature management strategies in aortic arch surgery, comparing mild hypothermia to moderate hypothermia with the neurologic and renal outcome as our primary endpoint. Briefly, this is the first aortic trial in type A aortic dissection, looking at a traditional hemi-arch approach versus an extended arch approach. This is in its pilot or vanguard phase and just started to enroll a few months ago. And finally, this is a non-randomized study, but a study looking at predicting aortic growth and outcomes in patients, started initially by Thais, who's left for Mayo Clinic, but continues as UOHI as the sponsor. So in addition to the clinical care provided by the thoracic aortic team, I would say we are trying to pave the way towards better evidence in thoracic aortic disease. Finally, I'm just going to put a pitch here for a meeting that we're hosting at the Heart Institute in the fall, September 5th and 6th, which is really focused on aortic root and ascending aortic surgery, as well as the aortic valve repair, which will be held right here in this room. With some live cases transmitted from our OR. So we'll pause here and maybe have a few minutes for some questions.
Thank you so much. That was great. There's a lot of questions here, so I'm going to try and go through them kind of quickly so everybody gets answered. So first question from Dr. Garuba. Are there any updates to the surgical thresholds for repair prior to pregnancy or intrapartum in women of childbearing age?
Good question. There aren't any evidence-informed recommendations, unfortunately. We use, to summarize, we would say, anyone at 4.5, certainly pre-pregnancy should be considered. If the aneurysm has been discovered after they're pregnant, then it's a bit more challenging in terms of managing them through their pregnancy and timing the surgery. For patients who have syndromic disease, and maybe Jodi can comment on this, anyone over a size threshold of 4.0 needs counseling on timing of pregnancy and potentially pre-pregnancy repair. I don't know if you want to add something to it.
But if there were other features that would put them at higher risk, then we would chat with cardiac surgery and talk about repairing them earlier, so closer to the 4-centimeter mark before pregnancy.
Okay. Next question from Dr. Shamoon. We pick up a lot of dilated aortas on echo when their size is between 40 and 45, but when indexed to body surface area, it is normal. And there is no growth over, 3 echoes over a number of years. Would you still recommend repeating the echocardiogram every 2 to 3 years?
So generally, no. If the patient's indexed aortic size is normal, there's no growth, then typically we don't. But again, this is not something that's been well studied, and so we don't really have a clear answer. I guess I would also look to other potential risk factors. So family history. Is there any concern over this being some form of a genetic aortopathy? But otherwise, no, we don't know exactly what a normal aortic size is, and certainly bigger people have bigger aortas.
The only one other thing I would add to that is the patient age. So if they're 40 and they have a slightly enlarged aorta, I probably would image them every 5 years. But if they're 75 or 80, probably move on.
I guess that leads into Dr. Johnson's question, where he asks, what is the oldest person that you've performed aortic surgery on, and is there an age or dimension where you stop screening? You mentioned someone, if they're 80 and they're 5, do you just stop the screening process going on?
93.
Oh,
and
okay.
A very fit, healthy, active, independent 93, right? Okay. So with an acute aortic syndrome. So yes, that's kind of it really defines the limit. We've done, patients in their 80s will sometimes who are high functioning will sometimes have prophylactic aortic surgery because their aneurysm is 6 centimeters and they still enjoy good quality of life. And in terms of screening, I would say once the patients hit close to 80 and they are unlikely to ever meet a surgical threshold because their aorta is only 4.2, 4.3, 4.4, we stop screening. At that point, we tell them to just live their life and not worry about it.
Medical question from Dr. Phillip, who apparently knows a lot about turkeys. So apparently turkeys die suddenly from aortic rupture. Who knew? And their food has been supplemented with copper to make it better. So are there any, I'm just reading the question. Are there any, supplements that have been proven to be beneficial in humans?
Yeah, so there have been some studies looking at the role of diet and supplements in aortic aneurysms, and there's really been no consistent data outside of, a heart healthy sort of so-called anti-inflammatory diet, which is what we propose to all our patients. So, the fruits and vegetables, whole grains, heart healthy fats. Beyond that, no role for copper.
Dr. Burwash wants to know that about a CT assessment of the entire thoracic aorta and abdominal aorta to look for aortic dilation is of low value in patients with BAVs. Is that true? Should we be doing a whole scan for patients with the BAV or just the thoracic aorta?
Maybe I'll answer a brief bullet. So, if it's a non-syndromic BAV with no features, no high-risk features, then I think it's safe to stay constrained to the proximal aorta. But there are BAVs under other subsets in whom I think a full thoracic aortic or full aortic assessment would be warranted.
First, congratulations, Munir, and Kathryn for developing the program, which is now obviously world-renowned, and the leadership with the Titan trials, very exciting going forward, and also exciting to see Jodi and Ming joining the team in recent years. It's really a fabulous program. My first question, I got two questions. The first is, you talked about the data, Kathryn, and I just wanted to make sure that the data from the clinic is also being collated and acquired, not just the surgical patients. Is that correct? Okay, wonderful. And the second is, to Ming, what constitutes an experienced surgeon?
I'm not sure if they truly qualify that in the guidelines. It's up to the discretion of individual surgeons to think whether or not they're experienced themselves. But I think there has some data in terms of volume outcome relationships in other sets of surgical literature that suggest that perhaps at least operating on more than 10 or 20 cases a year in that same specialty would decrease surgical risk. And also depending on your historical data in terms of how your patients do. If your mortality is like lower than 1% and the risk of dissection is 2 or 3%, perhaps, then you would consider yourself as an experienced surgeon versus otherwise. Yeah, thanks.
Thank you so much, team. That was excellent. Great discussion. Lots of questions. We'll see everyone next week.
Thank you. Thanks.